Thank you, Alan. Thanks for the introduction, as well as thanks for the kind invitation to be here. It's a pleasure to be here. I'll probably turn off my lapel microphone so that it doesn't give feedback. Yeah, I've been. Can you folks hear me? Yeah. So I've been called a lot of things, but not a YouTube social media influencer. So that's a new one. I will take it back to my adult children. It's an oxymoron, I know, but that's how they behave. I'm just kidding. So, what does the future look like in terms of non-PAP alternatives and treatment of sleep disorders, in this particular case, obstructive sleep apnea? And I'm going to fall back on our favorite president, Abe Lincoln, who's famously said the best way to predict the future is to actually create it. So you folks here, based on what I'm hearing and all the time, as well as part of this particular event, our focus group that Alan was referring to, there's a very, very bright future for all sleep disorders. And especially, there's a fantastic opportunity for dental sleep. And I know that is your passionate area of interest. And I do think that when you try to predict the future, I really think it's in your hands to create the future, and I know many of you know that, but I'm just underscoring that fact. So the objectives of my talk are to identify the current role of oral appliance therapy and hypoglossal nerve stimulation therapy for the treatment of obstructive sleep apnea, but I'll be primarily spending more time on the oral appliance therapy or mandibular advancement device, or whatever you want to call it. And we also want to identify some barriers and facilitators, which will be useful, I think, for you to understand how can you bring this particular therapy to the forefront for all patient care, not just a select few. And what are some of the issues there? Well, with regards to access to care, a multidisciplinary team of experts, reimbursement issues or regulatory issues, some of which you folks are more experts than I am, but I'll give you the sort of the physician perspective or the researcher perspective. Current treatment guidelines, how it matches with that, the health policies of the land, and all of the other factors that affects that. So I think it could be stated that currently that the adoption of these alternative forms of PAP therapy are not optimal. It's not as widely available as it should. So there was a joint statement back in 2015 by Rama and colleagues, which had a multidisciplinary team there, joint statement from both the folks in sleep medicine as well as dental sleep, who said you should consider oral appliance therapy in someone who's not tolerating CPAP or who is refusing to even do a trial of CPAP based on what they see or what they hear or some concepts and thoughts that they have coming into this. But then when you think about inspired device therapy, there's another guideline that came out which talked about how adults with obstructive sleep apnea with a body mass index less than 40 kilogram per meter square can be sent to ENT surgeons, and that we should be counseling and advising those individuals, and also people who are morbidly obese with a body mass index of greater than 35, that we should be discussing and referring to bariatric surgery. So this is to say that we are not embracing what I call a PAP-centric model for obstructive sleep apnea treatment. And by PAP-centric, the focus seems to be more of, it's CPAP, BiPAP for everybody. And there's also questions emerging from these guidelines as to when would these alternative forms of therapy be considered as first-line therapy? And why should it be for someone who refuses CPAP? And why should it be for someone who's unable to use CPAP? Why cannot it be the first therapy that you offer? And I do embrace that concept. And I'll be touching upon some of the, perhaps the barriers there that are present. So in all of this, instead of being PAP-centric, I want you to understand that my philosophy is more patient-centric, or patient-centeredness should be the guiding points of life for how we treat patients with obstructive sleep apnea. Because, when you talk about precision medicine, it sounds really cool. And in the precision medicine concept, it is the right treatment to the right patient at the right time. So even for the same patient, a particular treatment which is right at 1 decade of their life may not be the right treatment at another decade of their life. And I have a patient with insomnia, and he did not want to take medications. And so he wanted to do cognitive behavioral therapy for insomnia. So I said, okay, I'll find you a way of doing CBTI. But then he travels, and he's a busy researcher and scientist. He doesn't have time to go multiple visits to go see the clinical psychologist. So I got him plugged in with what is called a shut-eye program, which is an internet-based, automated, algorithm-driven cognitive behavioral therapy for insomnia. And he did fantastic on that. He did great. 2 years later, he actually had a shoulder injury and had to have surgery, and subsequent to which the cognitive behavioral therapy did not work for him. At that time, he circled back to me and saying, it didn't work, it is not working for me, I need a medication. Because, this pain is, getting to me, and the CBTI technique and approaches are not working for me. So I gave him temporarily, for about 3 months, a medication to get him through that rough patch. And once he came out of it, he again wanted to go back to CBTI, or cognitive behavioral therapy for insomnia, and went back to it. So I have patients who have a CPAP device, but when they go camping, they have an oral appliance that they take with them because they don't have electricity, or they don't want to use a battery pack and be lugging a battery pack, in a backpack, climbing up, mountain slopes and things of that nature. So what I wanted to you to know, and for us to embrace, is that the patient is the customer, the patient is the boss, and we have to provide patient-centered care. And so I'm fully open to the concept. We all should be open to the concept, both from sleep medicine side as well as dental side, as well as the ENT surgeons or bariatric surgeons, that at the ultimate end of the day, if we are patients tomorrow, and some of us are, and I know I am, I want the best treatment for me that best fits my lifestyle. So I just wanted to say that an overarching principle of what I'm going to be sharing with you and what I operate under is to provide patient-centered care. So despite such clinical guidelines, even when it's considered as an alternate, not everybody is given the particular option, so adoption of this particular therapy by practices is poor. So the objectives of this talk, I'm going to just outline here, are just talk about what are the general goals of treatment of obstructive sleep apnea. Some of this is stuff that you all know by the back of your hand, but I just wanted to, for the discussion's sake, set that. The extended nature of PAP intolerance or PAP failure in patients with obstructive sleep apnea. I'm going to just define that so that we understand what it is, if that's the route we want to go. By the way, anecdotally, I wanted to say that as part of, device therapy, we were in conversations with FDA for, a different device. And the FDA was like, no, we don't want you talking to us about this treatment being for failure of CPAP. Do a head-to-head study, because when you're trying to bring a device into the market, you want to have these conversations with the FDA saying, okay, if I do the trial this way, are you going to give us the approval? So we do early engagement to see if we involve them and say that at the end of the day, if we finish this trial and we find a positive change, are you going to approve the device? During those conversations, when we are talking study design, we have FDA saying, why are you taking the treatment failures from CPAP? Go head to head. Go for a de novo patient. Go for a straight patient who has not tried CPAP. And so even the regulatory authorities are paving the way for alternative forms of therapies for sleep apnea. And I want you to know that because, of course, they are the primary organ that regulates both medications and devices in this country. So when should non-PAP treatment be considered as first line? I already touched upon that. And then I mentioned about the barriers and facilitators. And I want to talk about real-world settings. When you look at a clinical trial, I'm the first I do research studies. I have a research center that I direct besides the clinical center. and I do a lot of clinical trials and translational research. And I'll be first to say that the study that happens in research that we look for evidence in books, it's good for practice guidelines and such, but it's not the real world. And I'll show some instances of that. And everything that I say, has limitations, I fully admit, So, I just invite criticism, and I'm not saying this way or the highway. And I just wanted to touch upon what are some of the future directions. So that's going to be sort of the outline of my talk. So goals of therapy. And so the patient-reported outcomes, such as if it was sleepiness, difficulty sleeping at night, it was disturbed sleep, nocturia, waking up with a dry throat in the morning, feeling unrefreshed, not being able to concentrate. These are all patient-centered outcomes. These are all outcomes that matter to the patient immediately. And so clearly, that's a goal for therapy to make that better. But also the patient experience. You all run practices, and it's very important that the patient experience be sound, and that the patients are satisfied with the services that you provided. They don't have to go through gymnastics. I just heard this morning about how someone was trying to make an appointment with a practice, and some of the things that they're hearing was prohibitive. There were barriers for them to be able to access the care. And so that just puts them off for a condition that doesn't immediately seemingly affect them. And so then they won't seek attention if we make it harder for them. So the patient experience and patient satisfaction are very key. We want to reduce the apnea-hypopnea index. And you notice that the apnea-hypopnea index is not something I put as number one. Because, we seem to put the apnea-hypopnea index on a pedestal and worship it. But it shouldn't. There are other things that are important. And be it CPAP or any other device or any other therapeutic approach, treatment adherence is extremely important. And we need to improve associated comorbidities. That's a higher bar. Trying to give a dental device and reduce cardiovascular events. Trying to give a device and improve their blood pressure. That's a higher bar. Trying to give CPAP or dental device and trying to make a dent on their diabetes. That's a high bar. Unfortunately, I think there's an overreach going on in the sleep field. And that's why some of the CPAP trials have failed, the SAVE trial, the Advent-HF trial, because they're just going for the highest bar. Whatever happened to how a patient feels and sleeps and the energy that they have or the depression or the mood changes that they have after a treatment, that holds a lot of value. So it's important for us to actually define what CPAP failure is. We talk about, certain payers are making decisions here saying that you cannot, we're not going to approve, a dental device or Inspire device unless you failed CPAP. So let's go down that path. The field, shockingly, has not defined clearly what constitutes CPAP failure. So I did want to say, I'm just going to see if I can go back to the previous slide, here. I was remiss in saying that some of the thoughts I'm talking about here, you see a list of names in the bottom. So this was the multidisciplinary group of people that got onto that YouTube that Alan was referring to. So I just wanted to say as a nod to all of these experts, some of what I'm espousing here is not just, my thoughts, but it's out of the collective thoughts of these group of, experts. So coming back here, so we all got together and we decided, well, somebody's got to define what CPAP failure is. So this is a suggested definition of CPAP failure. How do you operationalize it? If a patient outright declines to even initiate CPAP therapy, that's actually a pretty big component. I had Anthem approach me a couple of years ago. This was before the pandemic. They approached me and they said that we're puzzled. We give prior auth for CPAP after someone gets a sleep study. And you find that annually they give authorizations for about 100,000 people to get CPAP, just Anthem, Blue Cross Blue Shield. And they say about 10% of them don't cash that prior auth. In other words, they don't even get the CPAP delivered. So you're talking about 10% of CPAP prescriptions that are being given are not even cashed. I mean, that's clearly a failure of that particular treatment. And if a patient discontinues CPAP therapy. We get so hung up on CPAP adherence or dental device adherence, but if someone outright stops using a dental device or stops using the Inspire device or the CPAP device, that's pretty major. It's not like trying to nuance about, oh, how many minutes are you using a night and things of that nature. And a lack of improvement of the primary sleep complaint. Be it whatever they came in the door with, what was their chief complaint, and it's not better. And significant side effects that outweigh the potential benefits that they're perceiving. It could be anything from epistaxis to, feeling bloated and whatnot that prohibits them. And adherence. If they're not adherent and whatever you do is not being able to correct the issue. And here it says from 2 weeks to 90 days, multiple efforts fails to do that. I did want to tell you that there may be some health policy landscape changes that are happening that may extend that 90-day period. It could become 180 days. There's a possibility. So just wanted to park it out there. That's all patient-centered. But provider assessed, it's failure to normalize the apnea-hypopnea index because, yes, we still worship the apnea-hypopnea index. Failure to improve sleep continuity, where there's persistent daytime sleepiness despite adequate CPAP adherence. In other words, they're using the CPAP, but they're still symptomatic. And if they fail alternate modalities, we do something called rescue therapy. They don't work on CPAP, or they are non-adherent. We try other kinds of AutoPAP devices. If they have bloated aerophagia, we try AutoPAP devices, things of that nature. One could argue that you're going from a $1,200 machine to now a $2,500 machine. Is it really worth that kind of rescue therapy when you have other treatment alternatives that are effective? So one could argue that at least in that context, that CPAP failed that person. And payer-based. So payers such as Medicare and Medicaid say, well, you got to be adherent, and that's the one where I told you that the threshold may change to a 180-day trial period rather than a 90-day rule period is one of the things that I'm hearing. And failure of the patient to report symptom improvement. And that's what the payer defines it. So I wanted to put all of these various definitions in there, but until today, I was shocked. I mean, I've been in this field for 20 odd years. I have not seen a clear definition of what constitutes CPAP failure, especially when you have other therapies that hinge on payer reimbursement only after CPAP, is considered to be failed. So you will see a lot of data on CPAP adherence. I spent the last 15 years researching CPAP adherence, and I can tell you that there are data out there suggesting, based on large databases, that CPAP adherence is about 70% in the United States. I'm not talking about the world adherence data, but in the United States. So we took 250,000 patients worth of data, out of which we had about 170,000 pieces of data where we had the median, we had the zip code information on this Encore, Anywhere software. And so we were able to geographically drop pins as to where these people are residing. And so where the red dots are the people who are non-adherent by CMS Medicare standards. And the blue dots are the ones who are adherent. You can see there's a sea of red. The number of red dots actually outweighs the number of blue dots, suggesting that there are more people in the real world who are non-adherent to CPAP. In this particular study, we found 53% of people in this 170,000 people were non-adherent to CPAP by Medicare standards, which is essentially at least 4 hours of use a night for 5 nights a week in 30 consecutive days over a 90-day period. There are others who looked at similar data from the same company, from Philips and also from ResMed, and suggested that adherence is 70%. And so I had people come to me and saying, how did you come up with 47% being adherent when they're saying 70% adherence? When I went into looking at the methodology of their paper, people who outright did not use the CPAP, in whom the device registered 0, they actually took them out of the analysis. Of course, right? And then I have DMEs come to me and they say, well, you should give prescriptions to my DME. Here's my adherence data. I was like, okay, what is your adherence? 80%. I was like, seriously? How did you come up with an adherence of 80%? And I asked them a couple of questions. What payers do you take? Oh, we don't take Medicare, we don't take Medicaid. So they take a higher socioeconomic class of people who have independent private insurance only. And when we looked at the same data, because when we drop the pins by zip code, we know the median household income. It's published. It's in the U.S. Census Bureau. You know what's the median household income in that zip code. As a sidebar, I want to say is that billions of dollars are being spent on research of prolonging our lives and keeping us healthy. Billions of dollars. That doesn't affect our health outcomes as much as the zip code that you live in. Look at the median income of your zip code. In the United States of America, you will live 15 years longer if you live in a zip code that's in the highest bracket of income quartile. It's called ZDNA. Your zip code determines your life trajectory and your health and your longevity. This was in the Wall Street Journal, even, and besides in research land. So there's all these things about social determinants of health that we're talking about, that you've heard about, stems from that. And look at this. When we looked at the lowest income quartile all the way on the left versus the highest income quartile all the way on the right, we put the adherent people in the green columns and the non-adherent people in the blue columns. You can see a stepwise increase in the green columns going from left to right, suggesting that as your income improves and you live in a higher median income, your adherence is better. And that's partly because of health literacy. People connecting the dots. If my blood pressure is high, it's a silent killer, it's going to affect my kidneys, it's going to affect my heart, I'm going to get heart attacks, strokes, I need to get my blood pressure control, I need to see a doctor, I have access to care. That is health literacy. Just because someone is a PhD doesn't mean they are health literate. I've had PhDs I've seen as patients, and they know concept about what's going on. They know astrophysics, they know planetary sciences, but they don't know that a high blood pressure running at 160 or 100 for a few years is a bad thing for their longevity. So two separate things, literacy and health literacy. So there's a health literacy issue. There's also access issue to a sleep lab or being able to use out-of-pocket money to buy CPAP devices and such. So I wanted to bring us into sort of the stakeholder theory concept. When we do research, when we embark on research, we're sitting here in a conference like this, someone is talking here with some great ideas, and suddenly a bulb goes off in our mind saying, you know what, let me try that particular, methodology of assessing the upper airway, which is non-invasive, using sound to reflect in the upper airway, and let me look at that new tool that you see right next door over there, right? So you go in there, it sparks an idea, and you want to put that into play. But that's not how my research is driven. My research is driven by stakeholder theory. And so the stakeholder theory is that I get the patients and the stakeholders together. You hear in this particular study about how to improve healthcare for our patients. We got the American Sleep Apnea Association, which is a patient advocacy organization. We got product manufacturers like Philips or ResMed. We got purchasers who are healthcare systems that purchase the insurance, and the payers who write the checks, like the big five insurance companies, principal investigators, other researchers not involved, the American Academy of Sleep Medicine in this case. It could be the dental societies in a different case, patients, and as well as all kinds of providers, ranging from the DME, the respiratory therapists, sleep technicians, nurses, psychologists, and physicians. It could be dentists for a dental research study. So we get them all together and say, what is the next burning question? What is the issue that needs to be tackled? This is how healthcare expenditures happen in Canada and the UK. It's not like, okay, let's just wade into this. It's got a great market. We're going to invest in that. We're going to get return on investment. That's not how it works. That's not how research should work. So that's our stakeholder theory concept. And then we have an initiation meeting to saying, okay, we're going to, and everyone who has a problem with this, speak now or hold your breath forever kind of situation. And then we commence the study, and we cannot change the study anymore, but we get these stakeholders to actually help our research, and so that then tomorrow we'll be able to find the research findings. The very same people who are part of the study from the conception to the performance now will become ambassadors to disseminate the findings. I had a CMO of Arizona Medicaid who actually was in my stakeholder group. And he gave ideas early on. And at the end of it, he said, Sai, you know what? If you show that this particular study that you're doing shows a difference, I'll pay for it. So I have the CMO of Arizona Medicaid telling me that he would fund that program, which is exactly what happened to our program. Now, why am I talking about stakeholder theory? So I had the good fortune of actually writing a paper with Edward Friedman. So when you talk about stakeholder, the term stakeholder was coined by Edward Friedman, who still teaches law in the University of Virginia. And so the basic idea there is that businesses and executives manage them actually do and should create value for customers. It's a very important concept. You know, this thing about the airline industry, you know, being too big to fail and propping them up, and now we are apparently giving billions of dollars of taxpayer dollars to IBM so that they can make chips for us to get independence from China, when it was essentially IBM that sent chip making to China in order to, you know, get better margins. I mean, geez, man, I just chose the wrong career. No, I'm just kidding. I still think I chose the right career. But the idea here is that you want to create value. Those companies that don't create value, they're going to be gone tomorrow. They're here today, they're gone tomorrow. Why is it that General Electric is still here? Why are some of the other companies still here? That they don't need propping up. They are, yeah, not General Motors, General Electric. And so, you know, things of that nature is the reason why I'm mentioning that is that we're entering into a very exciting phase for sleep apnea care. You need to embrace the stakeholder theory. At the end of the day, you need to create value for your customer, which is your patient. If you don't do that, and you're looking at margins, not volume, you're looking at boutique or Cadillac, but not access to care. You're going to make a good packet, but you're going to be here today and gone tomorrow. You have to create sustaining value to people, and so that's both within your organization as well as going outside your organization. So this whole stakeholder theory concept is a business theory. This is market forces. This is capitalism. In capitalism, you don't create value, you're gone. So I just wanted to embrace that. And that's something that escapes the viewpoint of some of my colleagues. I'll be the first to admit, it can't be all CPAP-centric. You got to create value for the patient. When the patient walks in the door, they should know that you don't have a philosophical bias, that you're open to giving them the best treatment at the right time to the right patient. They need to be able to have the confidence. And so this is a study that I was showing you about how it came into conception. We had peer buddies, we had patients helping patients, promoting CPAP adherence. And we did show that CPAP adherence was better. But our number one endpoint was patient satisfaction. I had a room full of sleep physician researchers, and we're part of the stakeholder, you know, the stakeholder model I was telling you about. And I told them that based on rankings from all these 8 stakeholders groups, the voting came up with patient satisfaction as the number one outcome, and therefore it will be the primary outcome for the research study. They were crestfallen. They wanted the CPAP adherence to be the primary endpoint, and they were just puzzled. And they were like, why is CPAP adherence not your primary endpoint? Well, that's how the vote happened, you know, and it wasn't a voting machine issue. And I said that it was patient satisfaction. And so they were like, they were disappointed. And so they were crestfallen. So I just wanted to say is that they're missing the point, folks. Is that at the end of the day, should be your lodestar. And so this is a study that we did with Evidation, which is the backbone of informatics for the All of Us research program. And you can see that better PAP adherence and better vigilance was associated with better patient satisfaction. You're talking twofold changes both ways. If you are less sleepy, you're twofold more likely to be happy or satisfied. What does that mean? There's going to be more people knocking on your door. There are going to be more business. You're going to grow your business. And so you all know this. You know, I feel like I'm preaching to you know, people who are not drinking the Kool-Aid but swimming in it. So where is the data? You know, I can still hear my mentor asking me when I still do all this fluff. He's like, "Where's the data?" And so This is essentially Epworth Sleepiness Score, a multiple study, meta-analysis. Look at the pooled diamond plot down on the bottom. It straddles the 0 line, which means that mandibular advancement devices are non-inferior. In other words, they're comparable to CPAP to reducing daytime sleepiness. They can go toe-to-toe with CPAP reducing sleepiness. What about post-treatment apnea-hypopnea index? Yes, that favors CPAP. But you see the diamond is shifted to the left and doesn't straddle the 0 line, suggesting that CPAP is more efficacious in reducing the apnea-hypopnea index. But don't worship the apnea-hypopnea index, because if you look at this plot, it favors the mandibular appliance because people are more compliant, people are more adherent to the use of CPAP. And that is why, going back to the previous slide, it evens out. So there's a big difference between efficacy and effectiveness. People use that synonymously, but they are two different concepts. Efficacy is, if I put in a sleep study, look at what happens to apnea-hypopnea index. Effectiveness is what's really happening in the patient's home in real life. How adherent are they, and therefore, what is the sum average of improvement in symptomatology? So I'm going to get to a few slides here that I'm going to show, which is part of what we call the REAIM framework. When you're trying to implement something in your center or your practice, you have to think about a framework of what you're doing. You can just wing it, incorporate it, go through intuition, but you also can look at a methodological approach saying, how many people can I reach? That is the R in the REAIM. What is the effectiveness of the therapy? Not efficacy, effectiveness of the therapy or approach. And what is the adoption? How many people are going to embrace that? And what about the implementation process? How difficult or hard is going to be the process of implementation? Maintenance, which is how long can I sustain this? How long can I maintain this? A year out, am I still going to be doing this? Or is things going to change? So whenever you do, this is the concept of implementation science. People wing it or they go through a methodological approach. So there we identified what are some of the barriers and facilitators. So the barriers are, there's fragmentation of care due to regulatory agencies that prohibit co-location and employment. For example, if I'm a provider, I cannot be giving out CPAP machines. But you don't have that problem. You can have a DME license and you can do that. So it's more comfortable, better coordination of care, because you're not only doing the evaluation, decision making, but you're also issuing the CPAP, the dental device. And so that is a great sense of coordination and comfort for the patient. And some of the issues that we have with referring patients to dental may be probably a process of collaboration, but we were able to handle that. And similarly, different EMR systems was identified as a barrier, and that's an implementation barrier. Better communication or sharing the EMR system is an approach of tackling that. And the reimbursement denials, because the payer says you've had a CPAP device in the last 5 years, I'm going to deny it. I know some dentists who have a pro forma letter to Medicare that will actually do an appeal letter. They just substitute the patient name and check off a few boxes and boom, they got that. So they got that process, worked out, but also prompt return of the CPAP device by the patient within 90 days saying, hey, I'm not using it, and the patient, physician writing a prescription saying, discontinue CPAP goes a long way in apparently assisting with that issue. Out-of-pocket expenses, and that's a reach issue. I had someone tell me about how they got on the call and they said, well, put down $3,500 for the dental device, before you even see us. So that's a reach issue, because many people are making decisions about whether they're going to pay the copay for their cardiac medications or diabetes medications, especially if they're in the Medicare donut hole. And so those are things that affect access to care. And so maybe billing medical insurance would be a way of getting around that, because that is a barrier. Out-of-pocket cost is a barrier for people to be able to pay. Many dental practices are foregoing Medicare patients due to high regulatory burden. So either on the one hand, we lobby for a less draconian oversight, or we lose out those populations. I know that there are just one or two dentists in the Tucson area that actually take Medicare patients. Maybe there's more now, but that turns away a population. And so that earns a moniker of a viewpoint of how patients may perceive the practice. So just saying it as is. You wanted me to talk about this. I'm just telling you, which are things that you probably already heard. So Medicare, to reduce regulatory burden, as I mentioned, would be a facilitator. And there's some lack of trust as to whether eligible patients with the OSA are being referred for oral appliance therapy. And I can tell you, I'm a mentor for a dentist that is co-located with our practice, and he knows how much I support him, but he wonders sometimes whether I'm judiciously referring patients to him. And maybe I'm not, but I think we need to create that relationship building in order for us to trust, and also find out other ways by which I don't let those patients slip through my fingers, that I identify them so that I can make the appropriate referral. And also, some of that should be able to work out. And then credentialing and privileging issues are also a problem, but the one way of getting around it is to collaborate and be part of a multidisciplinary practice, or have one dental practice that you send all your referrals to. So you develop that relationship, tight relationship. The MAs here know the dental assistants there, and it's a win-win because we have an excellent relationship and we do team building. We do team building with our DMEs. Our sleep center gets our DMEs to come for a Pizza Friday. I've been doing this since my time in Chicago, and it really paves the way for a better relationship. So similarly, I think getting together and breaking bread is an approach, and so doing that with in between physician and dental practice is something that we should do. So I just want to talk a little bit about disruptors. There's this yin and yang. I want to bring these are all the usual disruptors, but the yin and yang is professions. My philosophical upbringing and background is as a physician versus someone else is that of a dental sleep person. We do have philosophical differences and issues. And in the interest of time, I'm going to skip through some of these slides, and I wanted to get to this. I don't know, how many of you have read the book Complications by Atul Gawande? Okay, so I see two hands go up. How many of you have heard about Shouldes Hospital? It was in the book. I don't know if it catches your memory. So Shouldes is a hospital in Canada that does only hernia surgeries. And there's only inguinal and abdominal hernia. That's it. That's all they do. The surgeon, day in and day out, does the same surgery. He doesn't do a gallbladder one day and a Whipple procedure another day and a whatever another day. He doesn't. He or she does day in and day out the same procedure. When you look at that, their complication rate or recurrence of hernia is 1% compared to the rest of the world where it's 10 to 15%. The reason why I'm bringing that up is that if you go, there is so much fish in that sea of sleep apnea, as you know. If you go all in, because it's a very bright area and bright future, but you get really, really good at it. And so that way you can actually give the best to the patient, and you make a niche area for yourself, which is what I try to tell my mentees in whatever field, in pulmonary or critical care or allergy or sleep, is to say, go all in that area. Don't try to be a master, a jack of all trades and a master of none. Be a master of one trade, And so there's a yin and yang going on that you should know. So it's not just, we worry about, there's the physicians versus the dental. Among the physician land, there's an issue about who's better at giving sleep medicine care. Is it the primary care doc, or is it the sleep medicine doc? And so there is research that I've been doing there, which has actually changed Medicare policy, I'm pleased to say. But according to this systematic review that was published in the Annals of Internal Medicine, they said it's no different. A primary care doctor is just as good in treating sleep problems as a physician. And so, but they conveniently left out one of our studies, And so when we included that study, we find that, yes, a sleep physician is better. So if you think that, there are differences in opinion within, maybe physicians, sleep physicians, and dentists, I just want to say it's like, it's an equal opportunity. Amongst physicians, we are fighting about who's better than the other person. So this is how the cookie crumbles. And so I wanted to bring it back to the sleep medicine practice-related barriers. And I know I'm 3 minutes shy of the hour, but I'm going to ask for a few more minutes because it was a late start. So I did want to talk about, the trust issue, which I already talked about, but also on a disagreement of whether oral appliance therapy is first line. There, I have to tell you that a supply chain issue and a device recall led to a lot of people allowing oral appliance as being the first line of care. And the evidence exists. Just because we find a research study doesn't mean it changes practice. In the area of implementation science, the research that was done was, it takes 17 years for 14% of physicians to change their behavior after the research is published in the New England Journal of Medicine. 17 years for 14% of practices to change their behaviors. Now, in the airline industry, if you have a plane crash, or if there's a risk of a plane crashing, Boeing can actually do a stand down of all of the Boeing aircraft across the world. In 72 hours, all the engineers, aerospace engineers, know what is the defective part, what to change, and they flip it out. 72 hours, 100% of Boeing aircraft, all of them have that bolt changed. In medicine, not a few hundred people die due to air crashes. 100,000 people die due to medical errors every single year. And it takes us 17 years for 14% to change. So I know I'm critical of my fellow physicians, but many of us acknowledge this fact, and we need to do better. We need to do better for our patients. So why is that important? Is that when you get frustrated that the evidence exists, but you're not able to change the behavior of these physicians, there's more work to be done under the REAIM framework so that you can reach out across the aisle and educate the other side of the aisle, which is what this country also needs a lot of, is reaching across the aisle. So reimbursement issues and denials is another issue, and a reduced number and access to sleep medicine providers, as well as from a practice standpoint, the long-term sustainability for any of these and the access to multidisciplinary care. So we really need to go towards multidisciplinary care, where ideally a top-notch sleep center should seek accreditation, should have an expert in at least all the 4 areas. There should be dental or a relationship with a dental practice. There should be ENT surgeon, a bariatric surgeon, and a sleep medicine doctor. Only those centers should get accredited. The other centers should not get accredited. So it would be like a higher bar of accreditation. That's a way of making the policy work. So just 2 more slides. I want to say the limitations of my entire talk in terms of disclaimers is that I didn't talk about complex patients with underlying cardiopulmonary disorders. And I know that all of you are very diligent about that. If someone looks like they have an underlying medical problem in addition to their sleep apnea, I know you folks are going to reach out because they may be someone with COPD or lung disease or interstitial lung disease that would actually benefit from a BiPAP device or at least attention to their lung problem in addition to the obstructive sleep apnea. And admittedly, I did not talk about other non-PAP alternatives such as tongue stimulators or upper airway surgeries, other upper airway surgeries or positional devices. So where should the future research be? The future research should be in implementation trials, where we try to find out how we can take the evidence that has been generated already that shows oral appliance is comparable to CPAP, and how do we implement it in the real world? How do we change that curve of 17 years for 14% of practices to change their way of doing business? That's implementation science. There are some fellow researchers of mine, they're like, that's not research. So there's a sort of a pejorative elitism that's practiced in university and ivory towers. That is research too, because changing the behaviors of physicians in being able to embrace a treatment that's valuable to patients, that is patient-centric, is implementation science. It's as important science and probably will have more effects than any research that they do in the gene or in the proteins inside the body. And there needs to be a large comparative effectiveness research. And when I say large, I'm talking about 5,000 people. So we're doing an insomnia trial, which is a large pragmatic trial of what will be 1,200 patients randomized to cognitive behavioral therapy for insomnia versus medication like trazodone or Ambien versus a combination. Now, those are the kind of papers, you're talking 4-digit patient numbers, that makes the health policy people change what they write on the health policy. So there are lots of small studies, and you do a meta-analysis and you show that it's comparable. That's not going to change the policy wonks in Washington, D.C., folks. What changes is that getting a paper in JAMA or New England Journal of Medicine. JAMA and New England Journal of Medicine are not just read by researchers. It's read by the people writing Medicare policy. And they're looking for these big hitting studies. So the field of sleep medicine and dental sleep needs a large, thousands of patients worth of study, head-to-head comparison of dental device and CPAP. Unless we do that, I'll be here 10 years later, hopefully I'm not retired by then, or maybe I am, and talking about the same things. Because remember, it takes 17 years for 14% of practices to change their behaviors. So with that, I'll end. I appreciate your attention, and thanks again.